rehabmypatient.com has had a massive update. 1,000 strength and conditioning exercises have been added to the library for you to prescribe to your patients. Pictures, videos, fully customizable text, deliverable by email and WhatsApp. What is not to love? Go to rehabmypatient.com/physio matters for a 3-month free trial on us.
So, welcome back to Tuning It Over with myself, Justin Lin, and with Mick Hughes. So, Mick, tell us, why is rehab after ACL reconstruction so important? And do we need to be specific about it?
Good question, Justin. It's super important that we get really high quality rehabilitation after ACL injury, not just reconstruction, but ACL injury as a whole, because we certainly know that reconstruction is not the only choice, which is probably a very big, deep rabbit hole we could go down. But just for the sake of our time this morning, we'll probably focus on reconstruction. It's vital. You think about the ACL injury itself is a big insult to the knee, with a lot of trauma, a lot of swelling, a lot of pain. Bone bruising, concomitant injuries that may occur to the meniscus. So there's a lot of stuff going on inside the knee, which ultimately can lead, and often does lead, to arthrogenic muscle inhibition, which is devastating to the knee, and to try and get that quadricep muscle to fire back up again. And then put on top of that surgery, often within a short time frame. So you have like 2 traumas to the knee, and obviously 2 doses, unfortunately, of muscle inhibition. And the muscle inhibition just doesn't really restore back normally very well. And, compound that often with a reluctance to do open chain exercises that truly isolate the quad. And we're kind of thrown into a really, what I like to call a crappy roundabout, where you've got really weak quads that can't protect the knee joint. That often leads to pain and disability, stiffness, soreness, poor capacity to exercise, and that just continues to lower that person's function. And then they go to exercise again, and they go round and round and round on this really crappy roundabout, as you can imagine. So if rehab's just key, and especially rehabilitation in those early 12 weeks is really, really important, that we nail that rehabilitation to set them up for a smoother transition back to the things that they love to do. I'm conscious of time, and I just probably could talk all day on this.
That's
topic,
right. Yeah.
Ultimately, it's a really important feature to get the best out of the person, so they can actually go back to the sports that they love to do, or the activities that they love to participate in. And yes, surgery does stabilise the knee again, but it's less than half the job of getting this person back to doing the things that they love to do.
100%. I think that's a perfect answer to that question. There are a lot of things that I wanted to pick up on, but obviously with time and with your upcoming talk as well, this might be something that we can uncover a little bit later. We know that ACL rehab starts right after the injury. So in that case, with regards to conservative versus ACL, maybe let's start a bit more on ACL reconstruction first. Is there a perfect candidate, or what's the ideal candidate for an ACL reconstruction surgery based on your experience, or based on some of the evidence that we have up until now?
Probably the best candidate really, it truly is, and it's that person that's presenting with recurrent instability, is probably the prime candidate. Some would argue that, and probably rightfully so, to be honest, that another important candidate is someone who wants to return back to pivoting and twisting sports, young person in particular. And probably the younger they are, probably the more important it is. We talk about young, typically young in our ACL literature, because up until now, we probably didn't see too many ACL injuries occurring below the age of 14, but unfortunately now we are seeing a growing number of young kids, as young as 5 and 6, tearing their ACLs, having to have reconstruction. And that's that's a really problem area. Once again, we could talk for days on this, but you know, for me, it's really hard to, especially like I'm looking after a 10-year-old at the moment who's had an ACL reconstruction, and just mentally for these kids, they don't have the capacity to slow down. And you know, if you've got a 10-year-old kid just, you know, ultimately living their best life as a 10-year-old should without an ACL and pivoting, twisting sports, and they just don't have a foresight to the future to slow down. So sometimes, and I would certainly agree, this is probably the best treatment strategy, is to reconstruct, because you ultimately are protecting that knee. Yes, you'd argue that another joint trauma is not good on a 10-year-old kid who probably doesn't know how to rehabilitate very well either. You're kind of damned if you do, damned if you don't. But at least you're stabilising that knee and not letting the kid run around on an ACL deficient knee. As they do get older, you know, they probably have a little bit more mental capacity to sort of rehabilitate well and slow down. So, you know, you're 16, 17, you know, 18, 19-year-old male or female sort of got better understanding there, but they often want to go back to these high-risk sports, basketball, soccer, football. You know, in Australia, AFL is huge, and it's a 360-degree sport with lots of jumping and landing and really high demand on the knee. So, you know, that's where, and you're looking at the literature, that's probably, yeah, the best treatment option. You know, some would argue once again, fairly, that, you know, you can pivot and twist without an ACL, but I've also tried to rehabilitate a lot of, you know, 18 to 20-year-olds without an ACL back to sport, and I probably would say I'm less successful in doing it non-operatively than I am successful in those that have a reconstruction. So yes, the literature may say that, you know, people can return back to pivoting, twisting sports without an ACL, but I've also seen a number of people fail that pathway and end up having a reconstruction. So so ultimately you sort of come back to that, the best candidate is someone's having regular instability episodes, and countering all that age-related stuff. I had a 66-year-old lady who for 12 months and a lot of non-operative rehab still had instability episodes. And I was, you know, when I met her for the first time, and she had, you know, a number of physios looking after her for a while, and, you know, I just sort of looked at her rehab and I thought, oh, well, your rehab kind of sucks. That's probably why you're still having a lot of symptoms. So let's rehab for 3 months and let's get you back. And I could be really confident saying we don't have to have a reconstruction. And we did really good rehab for 3 months, and she still had instability episodes in her daily life. So I was like, well, you know, you are a true instability. You know, do you have true instability within your knee? And so it's surgery is going to be best for you. So so it's definitely a case by case basis, and you probably
absolutely.
But ultimately it's probably the instability episodes. The problem is it's how many instability episodes can you tolerate, especially in a young person, before you say enough's enough. I've heard cases of physios down here persisting on non-operative rehab in the presence of at least a dozen instability episodes, and despite good rehab, they're just being really stubborn and continuing to do rehabilitation without surgery, and ultimately leads to really poor outcomes. So it's one of the toughest areas for me as a physio, and probably physios across the board, is to try and be able to predict who's going to be more successful.
Is that why more and more? Sorry to interrupt. Is that why more and more people, or certainly here in the UK, they do sort of like that watchful waiting? So yes, we know that you have got some episodes of instability. Try rehab for, let's say, 3 to 6 months, and if it truly fails, then let's go for surgery. Do you think that's probably one of the better sort of solution to go forward from now, with all the evidence that we have?
100%. Yeah, like for the vast majority of people, that should be the choice that's put on the table to them, or the offer that's put down on the table. You know, the paid professional athlete who needs to go back to Premier League soccer, or a level of football or sport that, you know, pays their wages and earns them a living for a period of time. Sure, like, you know, these people have got very tight careers, and they've got they don't often have the time to wait and see, because that wait and see approach is effectively taking 3 to 6 months out of their career length, which ultimately can make or break their salaries. But the 99% of us who aren't paid in any way to train or play absolutely should be offered rehabilitation first, and high quality rehabilitation, not just a whole heap of straight leg raises and TheraBand exercises and balance exercises. A good rehabilitation program for someone that's had an ACL injury should look no different to a general resistance training program that a healthy adult or a healthy adolescent should do, with low rep ranges, heavy weight ranges, once the knee's settled and calm, of course. It usually takes a good month to 6 weeks for that to get back to a quiet stage. But once that knee is quiet, it should look no different to a regular strength and conditioning program, and periodized over the next 2 to 3 months to truly get that knee rehabilitated to a point where they can make a better choice about the treatment moving forward, with ultimately surgery coming into the discussion at a later date. Of course, there's people that have got repairable meniscus injuries that kind of once again override that, because you want to preserve the meniscus as well. So, of course, it's never an easy conversation when you meet.
Of course, 100%.
That's why I have 45-minute consult times to walk through all these choices with people.
Yeah, because it does seem like we need to consider their own scenario as well. What are they hoping to get back to? It's definitely an important component to discuss. I definitely want to get a bit more detail onto what a high quality rehab entails, because maybe when I was at uni, I was told, you start with swelling management, range of movement, strength, power. Surely it's more complicated than that.
Yeah. Look, the first month, it's get the knee calm and quiet however way possible. And it usually takes, from what I've seen clinically, probably a good 6 weeks for the swelling to reduce, the quads to restore back to a really good level that can tolerate loads, and get most of the range of movement back. So that's where physio skill sets, that's our bread and butter. That's what we are really, really good at, reducing pain, restoring range of movement. So massage, cryotherapy, TENS if you want to use it, any of the electrotherapies, I guess, if you want to use it to a certain degree. Basic quad setting exercises, straight leg raises, terminal knee extensions, towel squashes, calf pumps, all the stuff that we are really good at, that you can give to someone who's effectively day one post-op, all the stuff that we're good at. Once that person's sort of passed through that process, and you're kind of, and on average, it roughly takes about 6 weeks, some a bit quicker, some a bit later, but once the knee has got down to a grade 1 swelling, so on a swipe test where you sweep upwards through the medial gutter and you swipe down the lateral component of the knee, compartment of the knee, if you're seeing that fluid brush back on the down swipe, that's a grade 1. And if you've got grade 1 or less, that's a good sign the swelling's on its way out, and what you're doing at the moment's being well tolerated. Rough rule of thumb, if you can do 10 straight leg raises without a lag, and if you've got full knee extension and at least 120 degrees flexion, that's technically a quiet knee that's ready to try some loading. From there, pick an exercise that you like, knee extension, hamstring curl, leg press, squat. For me, I'd keep it in these early stages from roughly 6 weeks through to 10 weeks. So about a month worth of programming. I'll try and keep it bilateral to share the load, because that knee's still pretty load intolerant. It's not,
of course,
it's not really truly happy to accept a lot of heavy one-legged loads yet. And you'll probably find that it'll quickly swell up on you again. So I like to share the load for the first month in a lot of bilateral tasks, as I just mentioned before, with some some higher rep ranges around the 12 to 15 reps per set. So 3 to 4 sets, 12 to 15 reps, 3 times to 4 times a week, basically every other day. And those days in between are really good watch and wait days to see how the knee will respond. If the knee responds really positively, then that's great. Reload again the day after. Have another rest day, see how the knee responds. if it responds positively, go again. If the knee doesn't respond, then we have an extra rest day, maybe dial back the weight. So that's where it's important to have these discussions. If you're sending someone away with a program, it's don't try and train twice a day now, like what you did in the first month, or 3 times a day with all those easy bed exercises. This is a day on, day off, and that day off's a watch and wait. So that's the first month. That takes us roughly through to 10 weeks. After 10 weeks, we then probably transition into a little bit more single leg work, such as obviously single leg knee extensions, single leg hemi curls, single leg press, Bulgaria split squats, RDLs. The list goes on. Keeping that rep range up around that same volume of work. Making the knee sort of do that same work. And that takes us through to three and a bit months. Pretty simple stuff. And of course, if you wanted to, if the person was really eager to get back to running or jumping, you could probably start around that 12-week post-injury mark. If they've been tolerating things really well, you could probably start flirting with things like skipping or using a skipping rope or doing some pogos. You might even, try some, little box jumps. You might try some little simple hops and lands, or a single leg step jump and land. Once again, if you've got more time to play with, you might even transition them back into some running, some straight line running. The key thing for me is trying to rehab and drag out that first 3 months, because we certainly are seeing a body of literature out there that's starting to show that the ACL can heal, and if we can be part of that process, if that person is one of these lucky people that's showing signs of healing and recovering, then we're going to see that clinically about the 12-week mark, with a change in how the Lockman test feels. And then on subs, like if you had easy access to MRI, you'd certainly see a changing of the ligament, the ligament makeup with inside the knee. You're going to see a changing and remodeling of that ACL. It won't look perfect. It'll look far from its former glory till at least the 12-month mark, if we're being honest. But at 3 months, you should see a change. And what it may appear to be like is actually a partial tear. And it may even be reported as a partial tear compared to, that day one post-injury, and it's reported as an acute complete rupture of the ACL. So that certainly is something that I work towards. But that's effectively in my programming. That's probably how it looks. It's nothing fancy, but it certainly does the job.
100%. Yeah, I think from my experience, it's all about doing the foundations right, rather than doing all these fancy exercises. I think thinking from a principle point of view, check the swelling, make sure that it's quiet, like you said, quads really, really important, and then see and make the decision again. I think from what you were saying, it was from the Canon trial in 2023. Is that right? That said that, yes, ACL has got a potential to heal. From from what I remember, is it 50% of the people in that study that has shown?
Yeah, so
right?
So Steph Philbay and colleagues, it was about I think it was end of 2022 that paper came out. They basically did a reanalysis of the delayed. Let me get this right. The rehab group. The rehab group alone, and they found that those that were so they, looking at the Canon trial, about 120 participants, half of them basically went into surgery. The other half had the option of delayed reconstruction. By the time 5 years rolled around, 60% had effectively had gone into surgery. By the end of 2 years, 50% had gone into surgery. By 5 years, 60% had gone into surgery, leaving 50% and 40% respectively at the end of 2 and 5 years. So they reanalyzed the rehab alone group. And they, at 2 years, they'd found that 50% of that group, so ultimately what's that? We're looking at 15, 16 participants, had healed. or at 2 years, which is probably why that rehab alone group was doing really well in the whole scheme of things, and why they were continuing to live their best life in the rehab group, because they effectively had healed. So 50% of the rehabilitation group alone had healed out of the Canon trial, and that's without any formal bracing protocol.
Exactly.
Looking at how they were managed earlier was, let's just get you into rehabilitation. There wasn't any formalized bracing. So that's where that's really good treatment choice. Emerging out of Australia, and this data is going to be published apparently later this year, and maybe in the next month or two, the cross bracing protocol.
Right.
That's a formalised 10 to 12 week bracing protocol, and preliminary data out of that showed healing rate, or the process of healing occurring, certainly not healed, but healing. By 3 months was up around the 90% mark with a formal bracing protocol, which is 4 weeks locked at 90 degrees in a ROM brace, non-weight bearing, 4 weeks in a ROM brace, and then every week you're extending that range out by 10 degrees, so going from 90 to 80 to 70 to 60 to 50, and so on until you get back through to full range. Which is roughly around about the 10-week mark, and then you come out of the brace and continue and then get re-examined at the 12-week mark. That study design has been around, they've been capturing data for the last 12 months, maybe more, and they're about to publish their results sometime this year. But the presentation at a recent conference that I attended that started to show some of that early data was really positive. So it's yet to be reproduced, obviously yet to be published. So it's probably not get too excited. I personally haven't managed a patient yet, and those that I have sort of floated the idea with, unfortunately, they felt that the time in the bracing was going to be a challenge for them. They were laborious workers, and just didn't have the luxury of 4 weeks in a brace, or didn't feel like they could commit to that at that time. But once again, the right individual in the right process, it could be a really, really good option for some people out there. So I'm really excited by what's to come, and why, and to read that paper when it's finally produced. Because it could be a complete game changer. But
absolutely,
look, at the very least, those that don't want to go down that really strict bracing protocol, they've still got a pretty good.
There is some hope.
It's a hope. I always say to people, give yourself a fighting chance. Maybe a toss of the coin chance that you will heal, but at least give yourself a fighting chance. So rehabilitate for 12 weeks, give yourself a fighting chance. And look, see how the knee feels after 12 weeks. If you don't like it, if you don't like how it feels, then maybe consider surgery. But if you love how it feels, and you want to continue, then you've got every right to continue to rehabilitate.
That's really good news, actually. And I think I couldn't help but think about some of the patients that I have managed personally. Like, a lot of them, maybe because of the medical tradition background, and they wanted to get surgery straight away. But I think it definitely took some time to convince them, and then telling them some of the reasons why. And so some of them do have really good outcomes, just doing conservatively, even if they don't have, or especially if they don't have any goals to get back to high pivoting sports. And they certainly enjoy their life right now. 100%. That's really, really good. And I can't wait to read that paper again, which is coming out, did you say, in a few months' time?
It should be, so Dr. Cross and Steph Philbay. So Dr. Cross is a sports physician here in Sydney, Australia. Funnily enough, his dad's an orthopedic surgeon who operated a lot of knees back in the 70s, 80s and 90s. So he's kind of like going against the grain. But he'll be the lead author, I understand. And Steph Philbay is part of that project, who was part of the Canon trial, who we just spoke about. And I'll be lucky enough to actually shoot a masterclass with her next month on this very, very topic. So I'm looking forward to that. But from what I hear
100%.
is that that paper should be published in the next couple of months, and so watch out for that one.
Looking forward to that. Right, want to talk a bit more about return to sport. I mean, there has been loads of research done on this. We know that sort of like 6 to 9 months, depending on where you read your literature, please correct me if I'm wrong, is where we should expect them to get back to. I think previously there has been a lot of chat, like we really need to get to 9 months, because every month lesser than 9 months would increase the risk of re-injury. Is that right?
Yeah. So there's been a couple of papers in recent years that show, for every month earlier than 9 months, the increase of a second ACL injury occurring increases quite significantly, and depending on the paper that you read. But it's not only those 2 papers in particular. One showed 50% increase, and another one showed it was like a 7 times greater risk. There was a couple of different ways they reported their numbers. But there's also some great biomechanical work from Ender King and colleagues out of Sports Sentry through 2018, 19 and 20. There's a couple of papers there that showed even at 9 months, a lot of athletes that are trying to return back to sport biomechanically, that they have not restored their strength qualities and their power qualities in the way they move compared to healthy controls, or even they're close to their other healthy limb by 9 months. So yes, they may be strong, they might be mentally ready, they might have great quad strength, hamstring strength, but they certainly don't jump and land and cut and pivot and twist and turn as good as their unaffected leg, and certainly compared to healthy controls, they don't have that same great movement quality at 9 months. So, which once again probably is opening the door there for a second injury. So there's certainly some really strong data that this 9 month mark is probably a better target for people, and a safer target. Once again, the discussions I have with my and largely I look after non-professional athletes these days. I often say don't even, I say aim for 9 months, but realistically it's going to be 12, because you're not getting, even in a supported environment, 9 months is a really tough ask to restore all of your strength qualities, and you have to be super diligent, and you have to basically, train the house down for 9 months. And most people will meet, people that have got busy working lives, and may have kids and family or work commitments and university commitments, and you got a lot of sort of things tugging you in different ways. And the rehabilitation process for a vast majority of people that aren't supported financially or aren't within a great club environment with 24/7 physio, doctor, S&C support, we just don't have it. So I often say, look, 9 months would be a great goal, and write that down and have that as a goal. It's always nice to write your goals down, but realistically, it's probably going to be close to 12 months, and we're probably seeing even a growing number of people probably returning back to sport closer to 18 months in a non-professional setting. And there's definitely some emerging data there that people with this 12-month goal, a lot of people just aren't achieving this 12-month goal, but they are achieving the return to sport goal sometime between year 1 and year 2. Kate Webster's done some great work there in the ACL space, and following up with a large number of ACL patients who have, their expectations certainly weren't met from day one post-op. Their 12-month goal unfortunately wasn't met, but they were certainly returning back to sport a bit later than 12 months. So that's probably where we sit, and certainly the conversation around coming back earlier than 9 months really is reserved for that once again probably more so that paid professional athlete. And even still, you'd probably argue that someone that's young, under the age of 25, still got a lengthy career potentially ahead of them. If they're pushing hard and saying let's get back to sport around about the 6 month mark, you'd probably be trying to sort of shift their goalposts a little bit closer to 9. They still may come under 9 months, and sure, when you're in a professional environment, that those things can happen, but it comes at a risk, because biologically before 9 months we've still got a lot of graft maturity to occur. But when you weigh up all those other factors that are a part of professional sport, then that's probably one of those risks that the person's willing to take. But you'd still encourage someone who's probably later on in their career, and I've seen a number of cases, someone who's maybe in their last or second last year of their career, returning back to sport about the 6-month mark, so they can sort of finish off their career on a high. I certainly saw that. There was a well-known case of a professional Australian rules football player a couple of years ago, tore his ACL in March in the last pre-season game before the competition started, rehabilitated throughout the entire season, and came back to play in the semi-finals, round 1 of the semi-finals. So he missed effectively the whole season, played all the pre-season and played all the post-season, and they went to the grand final. So he played 3 post-season games, only 5.5 months after his ACL reconstruction, but he was into his second last year of his sport. So there are the cases like that too. So
of course,
kind of take every case as it comes, but the vast majority of people absolutely should not be aiming to get back earlier than 9 months. And realistically, they're probably closer to 12. My message to people who do train the house down and are ticking all the boxes and are strong and moving well is that look, if you pass all the tests at 8 months that I'm happy with, use that last month to basically train unrestricted, get more training into your system, work on those little finer parts of the game in a very safer, controlled way, rather than just run the risk of undoing all that great work. So that's kind of where that conversation goes for me, because you'll meet the occasional person who absolutely kills it, and you'll be really struggling to justify why they can't go back to sport, other than an arbitrary time value. But that's where you can sort of pull out the old 9 month.
Of course. Well, I don't know how true is this, but I've read somewhere on Twitter, like one of the football players in Bayern Munich, I think tore his ACL, 4 months ago, and I think he probably got back to training in like 4 to 5 months. I don't know how true is it, but like you said, there will be that guy that excels really, really well in the rehab, plus he's in a really supportive environment, so that potentially can happen as well. I think we also know that time is just one factor to consider, and I think with the research we move more towards like more criteria-based progression, so things like limb symmetry index, the ability to jump at a certain level. Is there a specific criteria or set of criteria that you use clinically to guide that progression?
I actually did a workshop on it last night, so you probably picked the great time to ask me if I'm still fresh. No, it's for me, it's a series of tests that I put them through. The research will probably say that there's no, it's a bit mixed with research, with the discharge testing. One, there's probably no uniform and consensus on what is a good return to sport battery of tests. Probably what is clear is that if you pass a series of tests and you use a 90% threshold of limb symmetry index, or a 90% score on whatever test you use, you reduce the risk significantly of a graft re-rupture. But we know contralateral second injuries to the injuries that occur to the contralateral side, they do occur, and that's probably not well accounted for in some of the discharge testing. So that's probably what the sort of asterisk there is, that yes, you may pass the tests. You are reducing the risk. You're not taking it down to zero. You still have a risk of re-injury to your graft, but you're certainly reducing that risk quite a lot. I can't think of the number. I know one paper said about 60% less. That was from Webster and Hewitt. If you pass a series of tests, you're reducing that risk significantly, but it doesn't take it down to zero. I think that's an important message we say to our patients, because I think there's often this perceived safety there if you pass the tests, and if you kind of pump up their tires and say this won't happen again, and you're bulletproofing someone, which is a common sort of word used these days. I think you're setting yourself up for a bit of drama later. So for me, quad symmetry index and hamstring, quads and hamstring strength are really key, especially quadricep strength.
Yep.
Not only are you searching for limb symmetry index here, but you also are trying to chase a high value of peak torque to body weight.
Of course.
And traditionally tested on an isokinetic machine, but you can get some relevant figures from an isometric test at 90 degrees. The numbers that you're searching there for are 3 Newton meters per kilogram of body weight for males minimum, and anywhere between 2.5 to 2.8 for females on their affected side, but also roughly within 10% of the other side as well, so to get that 90% limb symmetry index. So that's both quads and hams. The peak torque to body weight for hamstring isn't as high as 3, anywhere around the 2 mark for males, and 1.5 to 1.75 for females would be sort of those kind of figures there, because that's the massive limitation to limb symmetry index. You could be symmetrical, you could lay within 10% of the other side, but your output is crap. So a perfect example of this is the single leg hop for distance, which is often a common test, and I use it. But if you hop a meter forward, say like you're a meter 70, football athlete, you hop a meter forward on your healthy leg, you hop 95 centimeters on your ACL leg, you've got a 95% limb symmetry index. And if you use those 2 scores there, you high five yourself and away you go. But that score is terrible for someone that's so athletic and so powerful. So you want to also be looking at the distance covered or the magnitude produced on the testing as well. So don't always chase that 90% score. Also look at the distance covered or the height jumped as well. So that's an important thing that we often overlook.
Of course.
So quad strength, hamstring strength. For me, I probably have changed the way I do my battery of tests compared to a few years ago with the advent, with the ease of and accessibility of force plate data, and certainly seeing some work from Aspetar showing that vertical jump is a really important feature there that we should be looking at, both a counter movement jump but also a single leg vertical jump. Because the asymmetry C, particularly in a single leg vertical jump, often don't get picked up on a horizontal jump. And there's some nice papers out there showing that some people can hop and do a really good horizontal jump and land symmetrically and land with a good distance and land also within a 95% limb symmetry, and you'd be going, great, this person's. But they find a way to land differently when they hit the ground biomechanically, and they'll often cheat through their hip on their ACL side, so they won't flex their knee very well. They won't absorb that force very well on their ACL side. Now put them on a force plate and get them to do a vertical jump, and that changes drastically. And there's been a couple of papers show their limb symmetry index now has changed to about as low as 70% limb symmetry index, despite being able to hop with a 95% limb symmetry index on a horizontal hop. And the work from Aspetar has sort of shown that about the 70% mark. So 30% difference between limbs, and some other work has sort of shown that figure to be about 80%, a 20% difference between limbs. So it's quite drastic. And these are athletes these are 9 to 12 month athletes who are also pushing to return back to sport, yet they can't jump vertically and absorb that landing from a vertical way, which is often how you injure your ACL, landing from a jump, and also to a requirement of sport for a lot of people. Jumping up to header a ball in football, landing from a jump in basketball, AFL, netball, whatever sport it may be. There's a lot of vertical components to that sport, not the horizontal one. So that for me has been a game changer in how I look at my ACL. So I definitely do those double leg and single leg counter movement jumps. As well as some of the horizontals, but I definitely have trimmed down my horizontal testing to just a hop for distance. And I'm looking for the height of the person. So if the person's a metre 70, I want them to hop their height forward, or at least 90% of their height.
That is crazy.
And then and then I like the side hop test because it's a nice 40 centimetre height side hop test where the person hops medially and laterally for 30 seconds continuously over a 40 centimetre line. Some nice normative values out there: 55 plus for males, 45 plus for females, within 10% of either leg. It's a good test of capacity to go back and forth for 30 seconds. It burns them out, but it's also a good sign of their confidence to be able to bounce left and right continuously, and also a good appreciation of their plyometric ability as well. If they can bounce continuously, that's a good sign they've got some of that plyometric capacity. So it ticks three boxes. It ticks three boxes off in one test for me. So it's a really good one to do. So so they're my sort of physical tests that I do, but I also make sure they do an ACL RSI questionnaire, a TSK 11 questionnaire, and I'll also too give them IKDC and COS ADLS questionnaire as well, just to get a good sense of their overall knee health and how they're feeling in everyday life.
Just from this is going to change so many of our viewers, listeners' practice as well, certainly mine, because from what you said, like, I've actually never thought about the vertical jump, and actually it's their height rather than the LSI, because it's quite superficial just to consider things like that. So this is a real insight that I'll definitely take it on and try to see if we can implement it. Mick, it's an absolute pleasure to have you on, and it's definitely an honor for me to pick your brains with all things ACL. We know that you're big. We know that you're big on social media. You're always so kind in sharing your information, including the one and only Melbourne ACL Guide. Is there a place where our viewers, watchers can find you and they can appreciate more of the work that you've done?
Thank you. It's nice of you to say and give me the opportunity to come and share some great information. A lot of this great stuff gets hidden behind paywalls, and I've been definitely been given a great opportunity over the last few years to certainly sort of dive into the literature a little bit. But I share a lot of information both on my Instagram channel, Hughes.physio is my handle there. Facebook, you can find me on the same handle. YouTube, I share some videos there. Twitter, a bit different. It's Mick W. Hughes is my handle there. They're the main sort of Mick Hughes sort of platforms. I've got a website, www.mickhughes.physio. Once again, you can find some stuff there. And then there's also learn.physio as well, which is my baby in terms of sharing both paid and also a lot of free content there for people to digest as well. So lots of places you can find this stuff.
Yeah, you've been blessing the ACL community with all the good stuff. Well, certainly the ACL, the Melbourne ACL Guide, because that has definitely improved my knowledge on ACL a lot. So thank you for that. You are coming on Therapy Live on the 24th of June for a session on ACL reconstruction rehab. Without touching too much of some of the stuff that you are going to tell us, well, although you might have shared a bit more from our chat just now, maybe give us a bit of a teaser on what you might touch on, so that our viewers can know a little bit.
So it goes for about 45 minutes, and I'll allow for hopefully a few questions there. But my talk's really going to be about trying to find the very simple ways to improve ACL outcomes, ACL, and specifically for this one, just for time demands, ACL reconstruction outcomes. I've titled it the 4 simple ways you can improve ACL reconstruction outcomes, looking at just really the very simple yet high quality ways you can better your patients' results and get them back to their previous levels of sports and get them back to the things they love to do. And these 4 things in particular are the things that I've just clearly seen and over the years, and meeting people for the first time who've been through a series of physios or haven't had successful outcomes, and you hear their stories and it's like, okay, well, You're not doing this, and this. These are just simple evidence-based, low-hanging fruits that we can pick from the apple tree. Why are people always sort of going so high up that, the shiny tree? Looking for those really bright, shiny, fun, cool things to do when you just got all this great stuff hanging low that you can pick and choose from. So that's what my presentation's all about, to show you those very 4 simple things to get the best out of your patients.
Absolutely. I'll definitely be the first one to watch that as well on the 24th of June. So tickets are still available for those that are interested. It will be associated with this video. Mick, thank you once again for joining us today. I know it's quite early on your side, so definitely appreciate you taking the time out and waking a bit early today.
No, anytime. It's been great chatting. Thanks very much for the opportunity. It's been great.
Test, don't guess. We all know that. We want you to test better. Valve Dynamo is a dynamometer specifically designed for MSK healthcare. It isn't a repurposed crane gauge or an inaccurate grip measure. Push, pull, grip, and more. Plus, if that wasn't enough, its app for recording and storing the data is just brilliant. valvehealth.com/dynamo for the only measurement device you'll ever need in clinic.